Postmenopausal Osteoporosis by Group 2, Kayelalah Asanion, Anjenelle Rosario, Lisa Hanson, and Marie Angeline Lim.
IK is a 75-year-old Caucasian female with a history of osteoporosis, presenting at her PCP with persistent low back pain that radiates into her lower extremities. She describes achy and sharp pain that is a 9 out of 10 on the pain scale. The pain worsens with certain movements and is alleviated by resting. She is currently under the care of several specialists, including an interventional spine clinic, an endocrinologist, and an orthopedist. She has recently changed her bone strengthening medication from Fosamax to Tymlos. A CT scan shows a new fracture at the anterior aspect of her right sacral ala. She has a history of hypertension, bradycardia, for which she has a pacemaker, pernicious anemia, hyperlipidemia, and she is postmenopausal. Her vital signs show slight elevations in blood pressure, heart rate, and respiratory rate as a result of her pain. IK has also lost height. At her tallest, she measured 152.4 centimeters and is now measuring 144 centimeters. This has been a slow decrease over the last 10 to 15 years. Though her BMI is 31, she has a very small frame. Risk factors for osteoporosis can be divided into two categories: factors we can change and factors we cannot change. Those risk factors we cannot change, but do have a heavy influence on osteoporosis, are gender. Females are much more likely to develop osteoporosis than males. Age. The risk becomes significantly greater for both genders as we age. Frame size. Those with larger frames have a lower risk than someone of the same height and gender with a small frame. Ethnicity is another, with Caucasian and Asian women having the highest risks. And a family history of this bone disease is another risk factor we cannot do anything about. There are risk factors we can eliminate or at least diminish. Hormone levels are factors in the development of osteoporosis, and supplementing where necessary can help. Being at a healthy weight, not overweight but also not underweight, will help us maintain bone mass. Having a daily intake of between 12 to 1500 milligrams of calcium with vitamin D will help to keep bones healthy and strong. This number is made up of what we consume through our diets as well as supplementation. And finally, having a healthy lifestyle and reducing our comorbidities will increase our overall health status. Not smoking or consuming large amounts of alcohol, as well as having daily weight-bearing exercise and eating a well-balanced diet, are all part of these healthy choices. Osteoporosis is called a silent disease because it often has no symptoms until the damage is done. Patients may experience several symptoms due to the changes in bone structure and the connectivity of tissues. These include severe back pain, either diffuse or in a concentrated location. Patients often experience loss of height and may even begin to have a stooped posture and experience kyphosis or other spinal deformities. Many patients discovered osteoporosis because of pathological bone fracture. This is breaking a bone when the force should not have broken bone. When this happens, osteoporosis will be the differential diagnosis. As in the case of IK, these symptoms are presenting from severe back pain to height loss.
Pathophysiology. In adults, the daily removal of small amounts of bone mineral, a process called resorption, is balanced by an equal deposition of new minerals in order to maintain bone strength. When this balance tips towards excessive resorption, bone weakens and over time can become brittle and prone to fracture, causing osteoporosis. The balance between bone resorption and bone deposition is determined by the activities of two principal cell types, osteoclasts and osteoblasts. Osteoclasts break down the bone and is responsible for bone resorption, while osteoblasts are in charge of bone deposition or laying out of the bone matrix. In a typical bone remodeling cycle, osteoclasts are activated first, leading to bone resorption. Bone formation begins as progressive waves of osteoblasts form and lay down fresh bone matrix. Because the bone formation phase typically takes much longer than the resorption phase, any increase in remodeling activities tend to result in a net loss of bone. Hormones are possibly the most crucial modulators of bone formation. Estrogen has three fundamental effects on bone metabolism. First, it inhibits activation of bone remodeling, promotes apoptosis of osteoclasts, and prevents apoptosis of osteoblastic cells. Estrogen levels dramatically decrease after menopause. As much as half of a woman's total bone loss occurs within the first 10 years following menopause. The lack of estrogen enhances the ability of osteoclasts to resorb bone. However, osteoblasts do not rebuild more bone. This results in bone loss and osteoporosis, in which there is decrease in bone density and increase in the chances of fractures. Pathophysiologic implications for presenting case. In the case of our 75-year-old female, risk factors included being postmenopausal, a BMI of 31, Caucasian, and being female previously diagnosed with osteoporosis. The body mass index of 31 is under the category of moderately obese, which may put a strain on the body's bone structure, which is already weakened due to osteoporosis. As previously said in the risk factor slides, Caucasians and Asian women have the highest risk for osteoporosis. Also, the acute and chronic back pain that our patient is experiencing is already a symptom of a fracture that has occurred. Though the case presentation does not specify compliance with regards to medication, it may also play a role in the occurrence of the fracture.
Diagnostics. Osteoporosis is characterized by low bone mineral density and deterioration of bone tissue. Osteoporosis is a T-score of less or equal to 2.5. Osteopenia is a T-score between 1.0 to 2.5. Osteopenia is having a lower bone mineral density than normal. It can increase the chances of developing osteoporosis. Dual X-ray absorptiometry is the gold standard for measuring bone mineral density to diagnose osteoporosis. It compares the T-score to the average bone mineral density of a healthy adult. The recommended areas for diagnostic exam are the femoral neck and lumbar spine region. Fracture risk assessment tool confirms osteoporosis diagnosis and need for pharmacotherapy. Pharmacotherapy is recommended for osteopenia T-scores between 1.0 to 2.5 and a history of fragility fractures. Osteoporosis may still be diagnosed with a history of low trauma fractures regardless of the T-score. Osteoporosis mainly occurs 10 to 15 years after menopause in women and around the ages of 75 years old to 80 years old in men. 10% is the average reduction in bone density in women during the menopausal transition period, 10 to 20% reduction in mineral bone density during the first 5 to 6 years of menopause. Osteoporotic fractures commonly occur in areas of low bone mineral density such as in the spine, the hip, or the wrist. However, incidence increases after the age of 50 years old. Osteoporosis is higher in postmenopausal women because of low estrogen levels, which is the key in maintaining bone health. Worldwide, Caucasian and Asian women are more susceptible to postmenopausal osteoporosis. In the United States, the majority of osteoporotic fractures are from Caucasian women. Treatment. Menopause hormone therapy, or estrogen replacement therapy, increases bone mineral density and prevents osteoporosis fractures. Recommended to take estrogen in the lowest effective doses for the shortest amount of time possible. Recommended for women at risk of osteoporotic fractures and who are younger than 60 years of age. Not recommended as the sole prevention method to prevent osteoporotic fractures. Bone loss will recur once hormone therapy is stopped. Pharmacologic interventions include use of biphosphonates, selected estrogen receptor modulators, recombinant human parathyroid hormone, and denosumab. Biphosphonates are considered the first-line drug choice therapy, and denosumab is the preferred treatment when patient has a history of renal insufficiency. Calcium and vitamin D are recommended for basic nutritional supplements. Lifestyle changes include regular exercise, focusing on weight-bearing, balance, and resistance exercise forms, cessation of smoking and alcohol consumption, and prevention strategies for falls.
Outcomes. Osteoporosis is a long-term condition, but proper treatment can lead to significant improvements in bone mass. It can decrease the likelihood that a fracture will occur. Bone mass usually does not return to normal after treatment, but the risk of fracture may decrease dramatically after treatment. Hip fractures are a particularly dangerous consequence of osteoporosis in the elderly. Approximately 20% of those who experience a hip fracture will die in the year following the fracture. So why is osteoporosis an important public health issue? In the U.S., 44 million people have low bone density. This amounts to 55% of the U.S. population aged 50 years and older. In fact, 1 in 2 Caucasian women will fracture a bone due to osteoporosis in her lifetime. This is a significant amount. In the U.S., direct health care costs from osteoporosis fractures amount to $1 billion, without even taking into account the indirect costs such as lost days at work and productivity. Approximately 20% of those who experience a hip fracture will die in the year following the fracture, as previously stated. So how is this prevented? Because this is a chronic condition, patient needs to establish an exercise program. Exercise makes bones and muscles stronger and helps prevent bone loss. It also helps the body stay active and mobile. Weight-bearing exercises done at least 3 to 4 times a week are best for preventing osteoporosis. Walking, jogging, playing tennis, and dancing are all good weight-bearing exercises. In addition, strength and balance exercises may help avoid falls, decreasing the chances of breaking bones. Patients need to be taught to eat foods high in calcium. Getting enough calcium throughout life helps to build and keep strong bones. The U.S. recommends a daily allowance of calcium for adults with low to average risk of developing osteoporosis is 1,000 milligrams per day. For those at high risk of developing osteoporosis, such as postmenopausal women and men, the RDA increases up to 1,200 milligrams each day. Excellent sources of calcium and milk are dairy products, canned fish with bones like salmon and sardines, dark green leafy vegetables such as kale, collards, and broccoli, calcium-fortified orange juice, and breads made with calcium-fortified flour. The body uses vitamin D to absorb calcium. Being out in the sun for a total of 20 minutes each day helps people's bodies make enough vitamin D. One can also get vitamin D from eggs, fatty fish like salmon, cereal, and milk fortified with vitamin D. Hormone replacement therapy can also help, like replacing estrogen, slow bones loss, and improves the body's absorption and retention of calcium. But because estrogen therapy carries risks, it is only recommended for women at high risk for osteoporosis. Fall measures should also be put in place to prevent other injuries. Another preventive step is to limit alcohol consumption and the cessation of smoking, as smoking causes the body to make less estrogen, which protects the bones. Postmenopausal osteoporosis is a common problem that causes the bones of women to become abnormally thin, weakened, and easily broken or fractured as they age. Women are at higher risk for osteoporosis after menopause due to the lower levels of estrogen, which is a female hormone that helps to maintain bone mass. This is a chronic condition and can be inevitable for some, but with proper treatment and injury prevention measures, the prognosis is usually good. Thank you for taking the time to view our presentation. Have a good day.